Okay, does everything look okay? Everyone see it?
Yes.
Okay. Hi everyone. So my name's Ryan Nolan. I'm a second year med student at UNR School of Medicine.
I'm
Um,
Harneet Sangha, second year medical student at the Elson S. Floyd College of Medicine in Washington.
so today we're going to be discussing portosystemic shunt embolization. So the full title of this study, if you didn't get in your emails, concurrent large spontaneous portosystemic shunt embolization for the prevention of overt hepatic encephalopathy after TIPS. And this is a randomized control trial. So before we get into the actual study and all of the details about it, we first wanted to give a little bit of a background. So we're going to discuss portal hypertension here, and portal hypertension can be defined by an increase pressure within the portal venous system by at least 5 millimeters of mercury. So if you get that measurement, then that's diagnostic for portal hypertension. And it can be due to a variety of reasons, but at the base of it, it's due to increased vascular resistance or increased blood flow. At greater than 10 millimeter of mercury pressure difference, then the patient's at high risk for variceal formation. So variceal formation rupture is a very feared consequence of portal hypertension, and it's emergency, and it has a very high mortality. So you definitely want to avoid that and be aware and prevent it from getting to that case. Again, the etiology can vary, but it can be broken up into three categories: prehepatic. So here, for example, fistula, thrombosis; intrahepatic, such as hepatic fibrosis, cirrhosis, alcoholic hepatitis, and we'll be focusing on cirrhosis today a little bit. And post-hepatic causes, sorry, a little bit of reverberation there. Post-hepatic causes, for example, due to increased atrial pressure. But the key idea here is that we have increased vascular resistance within that portal venous system. In the Western world, cirrhosis is the most common cause. And in this study, we'll actually talk about what their population had, and it wasn't cirrhosis. So that leads into some questions that we can discuss later. Portal hypertension can manifest as a site. Am I good? Okay, perfect. Splenomegaly, hypersplenism, hepatorenal syndrome, hepatopulmonary syndrome. So there are a lot of clinical consequences for these patients. Risk factors, some very common ones, of course, excessive alcohol consumption. Hepatitis B or C is very common, and also there's non-alcoholic fatty liver disease. Worldwide, it's the 10th leading cause of death in males. So there's a little bit of epidemiology there. So it's a very serious problem. Looking a little bit to review the pathophysiology and anatomy here on the figure on the right, you can see that we have the splenic vein, and then joining the splenic vein is the inferior mesenteric vein, and then joining that is the superior mesenteric vein. So when the superior mesenteric vein and the splenic vein come together, that forms the portal vein, and then intrahepatically goes into the right and left. And so in terms of the pathophysiology here, again, when we think about one of the most common causes of portal hypertension, which is cirrhosis related, there's a lot of fibrotic alterations and vascular distortion can cause stenosis. And so this increases intrahepatic vascular resistance. And then hormonally, there's increased vasoconstrictive neurotransmitters. So there's definitely a hormonal aspect as well that can increase pressure. Venous collaterals can form. So outside of varices, you can actually have the formation of vessels, and this is going to be a big topic in the study today. So we can have some from the distal esophagus, proximal stomach, rectum, umbilicus, and retroperitoneum. And of course, the variceal formation rupture is one of the most significant consequences as well. So going back to the formation of those venous collaterals, so spontaneous portosystemic shunts, or SPSS. So these are abnormal vascular connections, and there are different types. Some of the most common are splenorenal, periumbilical, gastrorenal, mesorenal, and this is forming between the portal venous system and the systemic venous system. So due to the increased blood flow or pressure within the portal venous system, there are going to be collaterals that flow. And it used to be thought as a compensatory mechanism to relieve pressure, but more recent studies have shown that it's not actually relieving any pressure. And really all it's doing is it's preventing hepatic perfusion, and it's diverting blood from the liver, and it can cause hepatic encephalopathy. So that's one of the primary outcomes that they're looking at in this study. And it is also associated with gastroesophageal varices, ascites, and et cetera, the previous consequences we mentioned. For a diagnostic workup, it's really important to holistically look at the patient. So you want to take a good history and physical and some laboratory findings as well. So a CBC can reveal thrombocytopenia. This could be due to GI blood loss, hypersplenism. You also want to do a comprehensive metabolic panel to assess renal failure, and you want to look for liver enzyme elevation, and of course a coagulation profile. So if you see an elevated or a prolonged prothrombin time, then that could indicate that the synthetic nature of the liver has gone downhill. So that can clue you into the fact that portal hypertension may be present. You could also get, in terms of imaging, look at Doppler ultrasound of the portal veins. So you're looking for stenosis or thrombosis, but you're looking for the direction of the flow as well. So hepatopedal flow is normal, but in the case of portal hypertension, you may have hepatofugal flow. And then, of course, the ultrasound can show evidence of cirrhosis, ascites, splenomegaly. If you suspect that portal hypertension is present and the patient may have esophageal varices, then you can do an upper endoscopy, and you can see here that in the bottom right corner, you see some evidence of pretty severe varices there that may be at risk for rupture. Here's an example just blown up of the Doppler ultrasound here. So this is showing hepatofugal flow. So this would be, you'd suspect portal hypertension in this patient here. So you can see in panel A showing the splenic vein, and in panel B, the right intrahepatic portal branch. Continuing on with the diagnostic workup, to actually get the pressure, and again, remember that 5 millimeters of mercury is diagnostic for portal hypertension. You could do a hepatic venous portal gradient. So ultrasound and fluoroscopic guidance. You typically get access to the right internal jugular vein, and then access the right hepatic vein, much like you're doing a TIPS procedure. And then you measure the free pressure, and then you occlude the right hepatic vein, and then you get the wedge pressure. So this is an indirect measurement. And this is preferred over the direct measurement as it's less risky and also less invasive, expensive.
Management options vary significantly depending on the underlying etiology, but treatment is centered around treating the cause. Medication, beta blockers if varices are present, and basically the function of beta blockers is to lower the risk of bleeding from swollen veins. Procedural, interventional, endoscopic variceal ligation. This is basically a procedure where elastic bands are put in the esophagus area, and they reduce the chance of enlarged veins bleeding. And then TIPS is going to be the main center of discussion for today's presentation. And TIPS is basically a procedure where a radiologist creates a tunnel and connects the portal system and the hepatic system, and the goal is to reduce the pressure. Management. TIPS reduces portal hypertension-related complications. Large spontaneous portosystemic shunts are associated with increased risk of hepatic encephalopathy in patients who receive TIPS. Large SPSSs, according to literature, at least some that I was able to find, are characterized as SPSSs that are greater than 6 millimeters in size. And also from literature, I was able to see that 70% of the time that the prevalence of SPSS approaches 70% among patients with cirrhosis and persistent overt hepatic encephalopathy. Transjugular intrahepatic portosystemic shunts per procedure, and to access the hepatic vein, you can use IVUS, which is just an ultrasound, creating the shunt, and then stent placement. And so this is just a question, like a food for thought question. Does prophylactic embolization at the time of transjugular intrahepatic portosystemic shunt of a large SPSS improve patient outcomes? And this is going to be the general theme of the study that we're going to look into today. Concurrent large spontaneous portosystemic shunt embolization for the prevention of overt hepatic encephalopathy after TIPS, a randomized controlled trial. Introduction and rationale. This study aims to determine if embolization spontaneous portosystemic shunts during TIPS placement can decrease hepatic encephalopathy in patients. And interestingly, this group also did a retrospective study. And the idea of this retrospective study was to see if embolizing SPSS before TIPS can reduce hepatic encephalopathy. And in that retrospective study, they were able to find results that agreed with their hypothesis, but they wanted to do a prospective cohorts, prospective randomized clinical trial, thus giving them the idea for this. And basically the study goal is, just to restate, embolization of large SPSS at the time of TIPS placement could reduce the risk of post-TIPS HE in patients with cirrhosis and variceal bleeding compared to no SPSS. Study design. It was a randomized single central trial conducted at a university-affiliated hospital in China. There's a total of 56 patients that qualified with cirrhosis and large SPSS, but over 469 total patients were screened. And interestingly, they characterized large SPSS as when the sum of SPSS diameter was greater than half the diameter of the portal vein, which is interesting and I think unique to this. Inclusion criteria was liver cirrhosis diagnosed by clinical presentation and diagnostic testing. I think they used CT. Ages between 18 and 75 years old, effective TIPS for variceal bleeding, having a large SPSS. Exclusion criteria, HCC or other malignant disease, portal vein thrombosis greater than 50% occlusion, previous TIPS, infection, uncontrolled hypertension, serious cardiac or pulmonary dysfunction, pregnancy, compliance, technical impracticability of TIPS. And then this study was almost 3 years long. It was greater than 3 years long, and they performed follow-ups at 1, 3, and 6 months after randomization, and then every 6 months after that, and every 3 months for 2 years. And for hepatic encephalopathy incidents, they actually told the patient's family how to screen the patients for hepatic encephalopathy. They had a questionnaire, and so every week, every morning, they would be required to answer these questions, and if they concurred with hepatic encephalopathy, they could talk about it during their next visit. Adverse outcomes, outcomes of interest, and study groups. They had 2 groups with 56 total people, one with TIPS and simultaneous embolization of SPSS, and one with TIPS alone. And this is just a flow chart describing the study design. And as you can see, 369 people did not meet the inclusion criteria. And the biggest reason for that was there was no SPSS or there was a small SPSS. And 44 people met the exclusion criteria, leaving 56 people, I think, in total. And interestingly, in this study, there's nobody lost to follow up. Everybody that had an appointment came to their appointments and everybody followed through with there was a high compliance. Study design continued development. So the primary endpoint or the main thing that they're studying is the development of overt hepatic encephalopathy within 2 years of TIPS. And hepatic encephalopathy was defined as an alteration in the CNS due to HE or portosystemic shunting, and they used the West Haven classification system to grade HE. And basically the West Haven classification system is a 4-point scale, and 1 point is for changes with minimal changes in level of consciousness, 2 points is for gross distortion, drowsiness, and 3 points is for marked confusion, incoherent speech, sleeping most of the time but arousable, and then +4 would be a coma. Secondary endpoints, or just additional things they also looked at, was variceal rebleeding, shunt dysfunction, mortality, liver function changes, other complications of portal hypertension, and adverse events in 2 years.
Okay, thank you, Harneet. So now we're going to talk about their statistical analysis and what they did to look at their data. So this was an intention to treat analysis. So this means that essentially if patients were enrolled and designated to a cohort, then they remain in that cohort regardless of dropping out, although there were no loss to follow-ups, or if they changed treatment plans. So this is good because it's really showing how this can apply more in real world scenarios. So less versus a per protocol analysis. For their test, they did non-parametric Mann-Whitney-Hugh. And so this was non-parametric, so non-standardized or data that did not follow a standardized distribution. And then they did chi-square and Fisher's exact test for qualitative measurements. For time events, so for their primary outcome, they did a Kaplan-Meier analysis. And of course, with that, they did the log rank test and as well as the Cox hazard ratio to determine significance as well as the magnitude of effect. They also interestingly included a post hoc analysis. So because they thought that the outcomes of death and liver transplantation were competing risks for their overt outcome, which was overt HE, they wanted to create a secondary analysis or a subdistribution hazard ratio to take into account overall death and liver transplantation in case those affect or prevent the patient from reaching the primary outcome, which is overt HE. So just looking at their table one, so baseline characteristics, we can see some interesting things here. So just keep in mind too, if most of these numbers here are medians or just ends and percentage. So the median age was 47 and 48, so no statistically significant difference there. Most patients were male. When we look at the pattern of SPSS, we see that most of these patients had a splenorenal shunt. So that is important to note. The total diameter of SPSS here was quite significant, 12.1 and 13.4 in both groups. And as Harneet mentioned, some of the literature defines a large SPS as greater than 6. Specifically in this study, I believe what they did was they said the total diameter of SPSS, if it's half or greater than the main portal vein, then that's considered a large SPSS. So that was part of their inclusion criteria. So you can see that the total area there is quite significant, and so is the total diameter. There's the ascites there, so mild, moderate, and massive, and you can see that there was no statistically significant differences between the two groups, but you could see the mild ascites was more prevalent in the TIPS plus E group at baseline. And importantly, something that I skipped over was that the etiology of cirrhosis in this population, so this took place in China, was actually HBV infections. So to 76 of the patients in the TIPS group had cirrhosis due to HBV infection, and it was 70.4% in the TIPS plus E group. So that's quite different than what you would see here. So that's just important to note. And also there aren't too many for alcoholic liver disease, autoimmune hepatitis. So that's something that we could discuss later when we're talking about generalizability of the study. And just going on the right, this is just a continuation of the baseline data. It's just too big to put all in one. They used both the Child-Pugh as well as the MELD score to classify patients, and they were similar in both groups. And you could see that the MELD score indicated a pretty moderate burden there, so a moderate liver disease. And the difference between the two is that the MELD score is based more on objective measurements. So INR, bilirubin, creatinine versus the Child-Pugh class is also taking account other subjective things like ascites, but is also taking into account the quantitative measurements as well. When we look at the bottom, we could see the reduction in portal pressure before and after the portal gradient, before and after the procedure. You can see that both saw relative reductions that were similar. And of course, when they actually did go ahead and embolize the SPSS for the patients in that group, they saw that the gradient actually went up for a little bit, but after the TIPS, it seems that both actually were pretty similar with no statistically significant difference. So this is their primary outcome that they were looking at. So if we focus on the left here and we look at this Kaplan-Meier analysis, the TIPS group is the blue line, and then the TIPS plus embolization group is the red line at the bottom. And so probability of avert HE is on the y-axis. This was a 24-month period, so they used that as their endpoint for follow-up. And you can see here that the probability of avert HE is lower in that group that received the SPSS embolization at the time of TIPS placement. With a hazard ratio of 0.38, that indicates a 62% relative risk reduction in overt HE, which was quite significant. And I believe that we have another table that shows the other values. But the number needed to treat here, they actually determined was 4, which is quite low. So that does show quite an improvement. With a number needed to treat of 4, that means that 4 patients would have to be treated in order for one of them to not have that overt HE. So 4 patients receiving this SPSS embolization in order for one of them to not have overt HE as an outcome. Looking at panel B, this is their multivariate analysis. So these are some of the things that they determined may be correlated with the outcome, which is over HE. And you can see here that the treatment itself was the most significant in terms of decreasing risk, and it was actually doesn't have the confidence intervals crossing 1. So that means that there was a significant effect of that. All of the other ones did have their confidence intervals crossing 1, except massive ascites. So you can see that's where increased risk for overt HE as well as previous HE was also associated with an increased risk of overt HE following TIPS. Here is, so when I was discussing the sub analysis for the Kaplan-Meier, where they controlled for death as well as liver transplantation, as they thought those may be impacting the primary outcome over HE, they still found that their adjusted hazard ratio was 0.35, so with a significant p-value. So they still did see a significant benefit of the TIPS plus E. And they saw that for both when they were controlling for liver transplantation as well as death. So here's more of a table representation here. So they had an absolute risk reduction of 29.5% in the group who received embolization. So 29.5% absolute risk reduction of overt HE. You can see the episodes per patient were 1.1 in the TIPS group and just 0.2 in the group that received SPS embolization. And so we also found they also found that there was a significant difference in the frequency of overt HE in terms of the number of episodes for the patients. In terms of these other outcomes here, so spontaneous constipation, GI bleeding, these they did not see any significant differences in. They did have secondary outcomes, and none of them saw a significant difference. So they looked at rebleeding for sources of rebleeding, shunt dysfunction, and importantly, they also did look at mortality. So they did not see in the TIPS plus E group an improvement in mortality. So they did see an improvement in their primary outcome, which is overt HE, but there was no difference in two-year mortality for this study. So that's important to point out. Liver failure, GI bleeding, HCC, liver transplantation, all of these were similar between the two groups. So looking at the limitations, and they did a really good job about addressing these themselves. So of course, it's a single center study. It does limit the generalizability in that sense, but something that is helping their generalizability is they did do an intention to treat analysis. And we'll also talk about maybe in the discussion a little bit their decision to use fluency stents and how that may change the generalizability and how that applies. It was also a relatively small sample size. They did do a power analysis, and they did get statistically significant results. However, with 29 and 27 patients, so around 55 or 56 patients, it is a relatively small sample size, but it was well controlled. But they did acknowledge that this can lead to some uncertainty for the estimates. The definition of large SPSS, so again, they defined it one way, and in the literature, other people define it other ways. So it may take a little bit of clinical reasoning to determine if a patient has large SPSS, and it may vary based on the provider. Covert HE before TIPS was not looked at as a factor. So overt HE was, and we saw that it was associated with overt HE following TIPS, but covert HE was not. So this is something that can be considered. I mean, it's difficult to look at and to control for, so it makes sense why they didn't look at it, but it is a consideration that they pointed out. And they also point out that most patients had cirrhosis from a viral etiology, so chronic HBV. So depending on the etiology of the patient's liver disease and cirrhosis, it may, or portal hypertension, then it may be difficult to draw a conclusion and to generalize it to different patients with different chronic liver diseases.
Takeaways. The TIPS procedure successfully performed in all patients. The portal pressure gradient reduction of 67.5% in TIPS E group and 69.2% in TIPS group. Primary outcome at 2 years, TIPS plus E had an absolute risk reduction of 26.9%, as Ryan was saying previously. And it's interesting that their primary outcome, like they already had a retrospective study that they did before this, and that one also agreed with these results and said TIPS plus E would reduce the reduction. Number needed to treat, as stated previously, was 4. So for 4 patients would need it to be treated for every one to have a decreased chance of episode of overt hepatic encephalopathy. Secondary outcomes, there was nothing statistically significant in the differences between the two groups. And I think that just speaks to the fact that doing this has no like side effects or harm because the results are similar in both groups. In patients with cirrhosis treated with TIPS for variceal bleeding, concurrent large SPSS embolization reduced the risk for overt hepatic encephalopathy without increasing other complications. concurrent large SPSS embolization should be considered for prophylaxis of post-TIPS HE. And we were looking through other literature as well, and looks like people have done like retrospective studies along these lines as well in the past as well. And they have found out that it does reduce the risk of hepatic encephalopathy when you embolize SPSS for the procedure.
All right, so thanks everyone. That's our presentation. And thank you, Dr. Schoenheit, for all your help, as well as the e-board for helping set this up. And thanks for everyone for your attention.
Good job, guys. It was a great presentation. Does anyone have any questions at this time?
Yeah, thank you, Ryan and Harneet, for that great presentation and for going through all of that so thoroughly. I was just wondering, considering that you went over the literature, what is the most reliable way to recognize a large SPSS? So here they kind of decided on that from their own experience, but is there an objective measure for large SPSS?
Yeah, I think they said greater than 6 millimeters in diameter, I think is what I was looking for other sources. It's variable, but it's around that, I think.
Yeah,
Okay.
that's what I have seen, cited in other reports is, and again, this is all we just decide a random number to say what's large, but that's what's typically reserved for large shunts and what I've seen in the literature.
Were any of these patients also treated pharmacologically for HE with rifaximin or anything, or did they only do the embolization?
Concurrently, I think they were treated with that concurrently as well. They were treated with both. If you can confirm that, Ryan, I think that's what they said in the study.
Yeah, I did. They did medically manage the patients as well if they did report HE.
So, hello, you guys here?
Yeah, we can hear you.
Okay, I had a question. If you could perform the procedure after the TIPS procedure was done, if there were any studies like that looking at post-TIPS procedure, if you could perform the embolization, if there are similar outcomes. We're not gonna stop.
So I personally am not aware of any particular studies that assess shunt embolization afterwards and its effect on hepatic encephalopathy. That being said, that is absolutely what we do. If we know that someone is having increased hepatic encephalopathy and despite their TIPS, refractory to medical management, and we know that they have a large shunt, we can take that shunt down. Yeah.
Hi.
Easier actually too, because you just go through the TIPS already.
Hi, thank you for that. I just had a quick question as well. Do you happen to know if there were any major embolization related complications that were observed? And if so, what are some complications that you expect from such a procedure?
I could answer. So Dr. Schoenheit could answer the second part of that, but in terms of this study, they didn't report any complications related to the embolization or the TIPS procedure itself.
Yeah, and as far as complications that you could theoretically expect from a malpositioned coil in this situation would all be dependent upon where the coil goes. So, certain vessels that are common in these situations that could be potentially problematic would be mostly your coronary veins or your left gastric veins that have a potential to be communicating with the coronary sinus. Again, in order to get a coil out there, you'd have to be very unlucky and very aggressive, but that I think would be the worst case scenario. But coil migration or coil malposition would be an area that I would be potentially concerned about. I know a partner of mine had recently an issue where the coil started to migrate to the coronary sinus and simply retrieved it with a snare and pulled it out just to make sure that wasn't an issue and put a larger coil in that was less likely to migrate.
Great, thank you.
Dr. Schoenheit, how do you decide if you want to do like a TIPS revision or an embolization or something in the middle?
Yeah. So those are tough questions. So I'll take a step back and kind of give, I'll give my 5-minute overview of what kind of my thoughts on the paper here. And then that'll lead into your question here. So I think this paper is excellent because it is a chance to show, it's basically a paper to show like, why is the sky blue? Because we all know it's the case, but no one had actually done the test. So we know that hepatic encephalopathy is caused by shunts that are taking away flow from the liver. Now, one of those shunts is, of course, a TIPS, that we will intentionally put into someone. So, of course, if you put in a TIPS without taking down a shunt, you're actually shunting more blood flow away from the liver. So you increase your risk of a hepatic encephalopathy. So the thought is, if you take down a vessel while you're putting in an additional shunt, then hopefully you're trading out at least a 1-for-1 situation in terms of the volume of blood flow that you're shunting away versus shunting now back towards the liver. To try and reduce progression of hepatic encephalopathy. So in my clinical practice, I absolutely, if my patient already has hepatic encephalopathy and I see a shunt during my TIPS, I will take it down. If I see a large enough shunt to compete with my TIPS at the time of the procedure, which is a little bit more of a subjective measurement, I will also take it down. And what my goal at that time is to try and keep blood throwing through my TIPS and not somewhere else, because I have control of the TIPS in terms of how big I can take this up, how, what additional things I can dilate, what additional things I can take down. Whereas the body doing its own natural shunts, I don't really have any control over that. So that's one that brings into Ryan's point about talking about one of the changes from this paper compared to what we do in standard in practice, at least here and the institutions that I've been at, is the fluency stent compared to what we use now, which is the traditional Viator stent. In the sense that the Viator stent is variable in terms of how large you can take it up, typically between 8 and 10, whereas the fluency stent they used was just a straight 8. So this paper was great because it standardized a technique that we don't typically do standard, because there's so many variants and tips, and everyone's individual anatomy often changes a lot of things in a tip situation. So to get directly at Tulsi's questions about when to decide about a tips revision versus a variceal embo versus other additional works on the tips. So tips revisions, I usually preserve to thinking of tips dilations or tips basically takedowns or constrictions, where you can deploy a stent inside the stent to try and decrease the lumen of your tips, or you take a balloon to try and increase the lumen of your tips. And again, that is all dependent on whether or not you're getting the results you want from your tips. So if your patient got a tips for bleeding and they continue to bleed, then you probably need to take your tips up in diameter in order to shunt more blood away from the liver, because still you're having significant portal hypertension. Whereas if your patient has overt hepatic encephalopathy, doesn't have any more shunts that you can take down, and your TIPS is at 8, then clearly you're shunting too much blood flow away from the liver. So you need to try and constrain that TIPS a little bit. So that's whenever you would try and shrink the size of the shunt at that point. So it all depends on what symptoms your patient's having and kind of how big of shunt you have and what that individual patient's anatomy is.
Thank you. That makes sense.
Perfect. The only other thing that I also wanted to mention is the one treatment that we didn't talk about as potential for variceal treatments or portal hypertension is what we call a BRTO, or what was traditionally called a BRTO, which is a balloon occluded retrograde transverse obliteration, where this is basically just a variceal embolization while we close down one of these large varices. So oftentimes it's what we call a splenorenal shunt, where you can access the systemic circulation, find the shunt, and actually get into the shunt retrograde and inject sclerosant or coils or something to close down that varix from that direction, again, to try and force blood into the liver. So I know someone earlier asked about, whether they do this after a TIPS. Well, yes, sometimes we'll do that after a TIPS, but sometimes we'll even do it before a TIPS. If your patient has such advanced liver disease that they simply cannot tolerate a TIPS, so if their MELD score is 30 or something along those lines where they're not a candidate for a TIPS, but they're still having bleeding, then you can potentially try this technique or a BRTO, or I think traditionally now most of us are moving to what we call CARTO or PARTO, which is just instead of using a balloon, we use a plug or a coil in those cases. 2 weeks before prophylaxis and E2H. Yeah, I think, we're talking about a little bit about the medical management of hepatic encephalopathy. They've made leaps and bounds in terms of the medical management of hepatic encephalopathy in the last probably 5 or 10 years. It used to be that if your patient ever had hepatic encephalopathy, we just wouldn't be doing tips for them. Interestingly, I think at our journal club last month, we actually presented the management of hepatic encephalopathy with a TIPS. You're intentionally creating a TIPS to manage their hepatic encephalopathy, because what they're doing at those times is actually doing a TIPS with this combined variceal embo. Again, as I talked about, trying to trade the degree of shunting from basically, if you add up all the shunts that they were to take down, it should be larger than the shunt that they're leaving behind. Because we have control of the tips, we don't have control over the additional shunts.
Yeah, to the comment in the chat also, it's a good point that they bring up in the paper as well in the discussion section. Just acknowledge that further investigation into combined SPSS embo plus rifaximin is an area of future investigation.
Yeah. More and more of my patients I'm finding are already on rifaximin or lactulose before they even get to see me. I think the hepatologists are starting to treat hepatic encephalopathy a little bit more aggressive. Somebody makes a great point there at the end. Yes, so the incidence of ascites on the follow-up, no. So that's, one of the things that I would have loved to see them test is the incidence of ascites in the TIPS plus embo versus just the TIPS group alone, because I could absolutely see the TIPS plus embo group having basically a less effective TIPS because of, or putting flow back towards the liver at those times.
Yeah, I agree. Definitely, that's the reason why I asked, because I mean, it might be something that you might want to avoid with people who have a lot of ascites before tips in that case, if that is true.
Yeah, and I honestly I'm not sure what that data would look like. I would believe that it would increase. You're increasing. I know from a fact that whenever you take down a shunt, you increase your portal pressure. So you're usually decreasing your gradient at the end of that. And typically for my ascites patients, I'm pushing their gradient much lower than my bleeding patients. Bleeding patients, I want to be around 9 to 11, something along those lines. Whereas my ascites patients, I'm trying to push them even lower, again, just to get a more robust response. So variceal embo in those cases is actually working against you a bit. So would be interesting.
Yeah. Another question in the chat is, or a comment, more and more are using carvedilol instead of nadolol and propranolol due to the alpha effect on the circulation. This may reduce the decompensation. And based off of new guidelines and multiple trials, carvedilol looks like a likely better alternative for reducing portal pressure. Predicist trial is a good one to look into as well. What are your preferred approaches for TIPS reduction in the setting of refractory encephalopathy?
So I prefer the constrained stent approach, where you basically will deploy a balloon expandable stent in like the dog bone technique, where you distally will expand to get apposition with your tips. Centrally, you leave constrained and then back the balloon up, and then again on the peripheral or more central aspect, blow it up till it hits the wall of the tips, and then that allows you to use that constrained portion within the middle to have a little bit more control. The other technique that's described is, oh gosh, I tried it once and man, it was just so cumbersome. You have 2 balloon expandable stents where you basically can fight the 2 of them where one of them shorter than the other to intentionally constrain the flow through the second tips. It's documented in the literature, it's technically feasible, but I have found it to be much more technically complicated than simply deploying the dog balloon expandable stent inside the tips. So follow-up algorithm for tips, when do we get ultrasound, EGD, and clinic follow-up? Those are, again, great questions. So, I was under the impression everyone was following up tips ultrasound within a month. That's how I was trained at Michigan. Then I come here and all of my partners are doing them within a week. So I was like, okay, if that's what we're doing, then that's what we're doing. I found no difference between the early 1 week follow-up and then the 1 month follow-up. One thing that I have found interesting is sometimes you can get a lot of artifact if you do the tips ultrasound too early. Like if there's been a couple times where we've done a tips and there's concerns for immediate tips dysfunction and they look along the tips and they can't see anything. It's interesting just because basically when we deploy the Viator, sometimes a little bit of gas can be trapped along the outside and just causes a lot of artifact. Exactly. Yeah. So we used to have a saying inside our post-op note that says, do not ultrasound the tips within 2 days, because it just has generated so many issues from the clinical teams. But my algorithm now is tips ultrasound in a week. They see me at first in clinic with labs in a month with CMP and CBC. And then they see me again at 3 months. And then often at that point in time, I'm sending them back to their hepatologist. We work hand in hand with the hepatology clinic here. Most of my tips are under evaluation for liver transplant. So that's kind of their primary care doctor, is their transplant hepatologist. There are a few that see me every year, but most of them are going to be followed by hepatology after that 3-month mark.
Awesome. Any more questions? Anything else you want to add, Dr. Schoenheit?
No, I think that the guys did a great job. This is a very exciting topic in IR. Everybody loves to do tips.
Yeah.
Somebody have a question there?
Were you gonna say something? Maybe not.
Yeah, so they just did one today. They did a PVR tips. I think they did it. Oh no, it was yesterday, right? Yeah, yesterday, and they did it. The Northwestern way with splenic access, IJ access, fluoro-guided flossing. It's beautiful, beautiful.
I saw that. So sad I missed it.
All right. Well, thanks everyone for coming out. Thanks, Tulsi, for hosting us here.
Oh,
What is my algorithm for PVR tips? Oh, great question. I wish I had an algorithm for PVR tips. Basically, if PVR without tips, I think, is largely unsuccessful. If you don't have some of the fundamentals in tips is you need good inflow and good outflow. So if you don't have good inflow, if your splenic vein is shut down, your SMV is shut down, your tips is not going to succeed. If you don't have good outflow, in the sense that if your tips isn't big enough or your tips is blocked from some direction, then your tips is not going to succeed. So making sure you have appropriate inflow, that there's no constrictions along your MPV, and then making sure your tips is patent. So as far as algorithm, who I would do it on, so patients who would benefit from PVR tips tend to be patients who have refractory or like acute SMV thrombosis leading to bowel ischemia. That's a patient that I would consider doing, direct intervention on from their in their portal system. And whether they need a PVR, it all depends on, what their underlying anatomy is. Most of the people who have some kind of venous mesenteric ischemia are going to have some degree of portal disease to start with. So those are the patients where I would do a PVR tips in order to keep their portal system open. That or patients who are potentially enrolled in liver transplant. And the reason is that the yes, the transplant surgeons can do much better jobs than they used to about finding non-native anastomoses for their portal veins. However, there's multiple studies that show that morbidity and mortality go up significantly when they use a non-native anastomoses. So trying to preserve the native portal infrastructure in these like advanced cirrhotics, I think is a worthwhile goal, especially if you're at a large transplant center. So I know the large leading people in the country for this, at least from what I have seen, have been the Northwestern groups. They have a techniques in VIR paper that is excellent for talking about the technical aspect of PVR. I think they strongly advocate for a splenic vein approach first. At least in the most recent paper I read, that they found that it drastically reduces the time and it's much more likely to find the native portal vein than trying to go transhepatic.
Lots of exciting stuff.
It is an exciting time to be in IR.
Okay, last call for any questions. If not, then I've just plugged our handle on Twitter and Instagram. Please follow us. And then tomorrow we have an exciting event with WCVIS for publishing textbooks as a VIR trainee. So definitely don't want to miss that. And again, you can follow WCVIS on Twitter also, and then you could get all the updates with them. All right, thank you all for being here. Have a good rest of your Wednesday night. And good job, Ryan and Harneet. And thank you so much, Dr. Schoenheit, for your time.
Anytime.
Thanks, everyone.